Пожалуйста, мы начинаем конференцию нашу. Первый доклад – это профессор Leroy, лапароскопическая гибридная или мiniинвазивная трансанальная хирургия. Пожалуйста. Так.
I'm connecting. It's okay. It's normal. Okay. Good morning, everybody. I'm Professor Leroy. I'm medical director of Rectal, Strasbourg, and I'm very proud to be invited by the organizing committee to participate to your congress. It's the first time I'm coming in Ukraine, and I'm happy to have met some people that visited our institute, and I hope in the future we will have more connection, more link to continue this approach and participation to different meetings in your country. So the topic proposed was to speak finally of the history of the surgical treatment in rectal cancer, and you will see a lot of things change. You have a lot of surgical procedure proposed using a perineal approach a long time ago with local excision and more and more preservation of the rectum. The first step in the rectal cancer was the technique proposed by Miles. He understood that local excision only will provoke 90% of local recurrence. And introducing the concept of gynecologic oncologic resection, removing the nodes and the meso, he found local recurrence around 30%. Bill Hill in 1982 described a technique that rapidly, after 10 years, was the world gold standard. It is a TME, reducing the local recurrence rate from 30% to 5%, removing the rectum and his meso with perfect respect of the propria fascia of the rectum. This is what he demonstrated. In the 90s, beginning of the 90s, arrived minimally invasive surgery. It is not a new technique, but a new approach for doing the same procedures with less traumatic abdominal access and parietal access. It was a technique that tried to reproduce the same technique proposed by Bill Hill in the 80s. I did my first with coloanal anastomosis in 91, probably the first in the world. It was a young male patient that had the preoperative neoadjuvant radiochemotherapy. How we do? It is well standardized. Rapidly, we standardize the procedure. We enter inside the abdominal cavity. We open, I think if there is less light, we will have a better picture for the people. Is it necessary to have the light here? Because the light is flashing on the screen. and we open the peritoneum to dissect the vessels, lymphatic, retroperitoneal. Then in the pelvis, we will dissect in the embryological plane, well described by Stelzner, and respecting this embryological anatomy, you have to know this embryological anatomy to finally see the right plane. It is a dissection between fascia. It is not a dissection of the rectum. At the end, you will have the rectum in your hands. You see, with the tools we have, we can dissect safely. This is a small electrode at the extremity of this instrument, 2 millimeter, that is dissecting. So the thermal energy used is very localized, using 10-15 watts for doing the dissection. We have introduced and developed with industry some tools to help the surgeon. And when you have this kind of instrument, this is a 0-degree scope, we can see the pelvis as we have never seen. I know that some people, and we had a discussion yesterday, said, since we have the robot, we can do that. I do that since 25 years now. And people don't understood that when we do surgery, it is traction, counter-traction, action. So we have to use 2 hands for working, and we have to use tools for retracting, and it is the key, and it was the key in open procedures. So it's not using articulated instruments that would be the problem, it is how to expose, and this is when we have understood this, that we can do safely technique of dissection. So we have introduced simple retractor with different shape to retract and to see very well. This is the anatomy as we have never seen. So you imagine for teaching, in the past, nobody, particularly the assistant, can see that, only the surgeon, but the head of the assistant was removed. Now everybody can see, and this is a dissection between the 2 layers of the denovidial fascia. This is a dissection of what we call in the past the lateral ligament of the rectum. You will see this is the extremity of the instrument, it's 3 millimeter. This is 5 millimeter, and the electrode is 2 millimeters. You will see the nerve, branches of nerve, neurovegetative branch crossing the space. This is the sacral branch. This is the inferior hypogastric plexus. And the branches are 1 millimeter or less than 1 millimeter. You will see half millimeter, and it is not the best picture because we have HD video camera, 2K, and now arriving 4K video camera. You will see the branches, and we can divide the branch at distance of the plexus. In the past, due to the traction, surgeons were putting a clamp and dividing at this level. And it is one of the dangers. If you don't dissect like this, you will not respect enough the branches of nerve, and you will have urogenital and digestive functional problems. This is a gift Dom Pérignon Champagne of Bill Hilt that promised to offer this bottle of champagne the day we'll see a laparoscopic surgeon reproducing exactly what he was doing by open procedure. And I had the gift, it was in IRCAL. Next step was preserving more and more the sphincter. So the preservation of the sphincter, and perhaps more, preserving the rectum to cure the cancer. Preservation of the sphincter was introduced not only, but by Gerald Marx. Gerald Marx proposed a preoperative neoadjuvant radiochemotherapy, and possibility to preserve the sphincter, and we will see what he proposed to begin by transanal approach and open procedure. His son continued to do that by laparoscopy. What is clear concerning the preoperative neoadjuvant radiochemotherapy? This therapy will increase the possibility in risk cancer to preserve more sphincter, avoiding definitive terminal colostomy. What is the effect? You see, radiotherapy alone, it's less than radiochemotherapy concerning the downstaging of tumor. And sphincter preservation will be more when we use both than only radiotherapy. Conserving the rectum. This is idea in the 80s, 83. You see, in the 80s, there was a lot of people thinking to do different. 81, it was Bill Hill. 83, you have Gerhard Booth that introduced the transanal endoscopic microsurgery or transanal endoscopic operations procedures. Using a specific device he designed, using binocular vision to remove tumor. It was proposed to do that by a different team, and you see Gerald Parks proposed to do that in patients that were fragile, and it seemed reasonable, and they were surprised to see that they had a local recurrence rate around 20%. Patients that were not easy to operate, and they decided to do this local approach. And it was a surprise. We can remove big polyp. Sorry. But what is the ideal local approach, the ideal case? It was concluded that it is a mobile tumor, less than 3 centimeters, well or moderately differentiated, non-ulcerated, with no lymphovascular invasion, classified T1 and 0. Now we have more information. T1 SM1, yes. T1 SM2, the risk of metastasis, of node metastasis, is around 10-15%. T1 SM3, it is similar to T2. You will have a risk of 20%, 25% of positive nodes. So we know that local excision is possible, but we have to select perfectly the patient. Some authors, Leroy, propose to introduce in early tumor, T1, T2, to associate radiochemotherapy. And this to have the possibility to have a complete downstaging and sterilization of the tumor, removing, and it was interesting to see that the results were very enthusiastic. What we can say, in 90% of the T1 disease and in 70% of T2, we do too much. It's not necessary to resect the rectum for all the patients. But the problem is it's difficult to determine if there is positive nodes or not. Using ultrasonography, MRI, CT scan, other technique, PET scan, for example, can be used, but we have no possibility to determine surely that there is no positive node. We have not also the possibility to have marker, actually, to determine if there is aggressivity of the tumor. So we can say that local excision for T2 rectal cancer is today not justified. local excision can be proposed for T1 tumor, but T1 SM1. After T1 SM2, too much risk, but we have to be sure that it's a SM1. So today, we consider that in rectal cancer, the TME is the gold standard. The problem is it possible to do the procedure we did by open bed hill? We did by laparoscopy, a lot of team. By transanal approach, to use a pure transanal approach for doing a TME. There was a lot of paper. To remember now, people are speaking of transanal, completely new. It was described in 1950 using open procedures, and Toupé proposed to begin by transanal to verify the possibility of doing anastomosis. So this is not new, and Gerald Marx proposed the same, and introduced, we will see, the term of TATA, transanal, transabdominal. Laparoscopic surgeons use similar technique. The first was John Marx, the son of Gerald Marx, that used laparoscopic TATA, beginning by transanal and transabdominal with trocar. French 12. Zoron introduced a term that is down to up, but introduced a fibroscope for doing the dissection. This is a very clever idea. And some authors, French, Dumont, described first the transanal and single port, not multi-port, but single port. And Antonio Lassi did the same with mini trocar. And Sergio Lara introduced the term of TAMIS with robotic. But TAMIS, it's mainly TEMS. This is transanal endoscopic microsurgery, and also TME, partial TME. Concerning the full transanal without abdominal assistance, trocar, incision, mini-incision, there is only two techniques today described. More authors are doing now because I receive a movie of different authors. Zhang, Chinese, that did a pure transanal using transabdominal approach. He opened rapidly the Douglas pouch, enter inside the abdomen, and do the procedure as we do by laparoscopy. And I have introduced the transanal retroperitoneal technique. I have called PROGRESS, that means perirectal oncology gateway for retroperitoneal endoscopic surgery. What it is? It is a technique of dissection, PROGRESS. It's not a new concept for doing a pure transanal TME or doing a transanal sigmoidectomy. For that, I'm using a specific platform that is different trocar, 7.5, 15, 20 centimeters, 4 centimeter diameter. We can introduce with different cup, possibility to introduce a fibroscope with a scope fixed on, so it is not manipulated by assistant, and having the possibility to use different type of instrument for improving the ergonomy, even beginning with a flexible cup as a glove connected to a sleeve as a single port to begin the procedure. This is how we fix the system. We have the possibility now to fix with a robotic arm that allows manipulation with a voice or foot pedal, and as you will see, the possibility to introduce robotic instrument as a fibroscope we use and we are developing actually. How we do? First, we close the rectum distal to the tumor to avoid the cancer cell spillage inside the dissection field. Then we will navigate with the tube around the rectum, posteriorly, laterally. We don't open the abdominal cavity. We will open it at the end to enter inside the abdomen and to reverse the rectum and to dissect the retroperitoneal plane That is the only plane that is fixed to the meso-sigmoid and mesocolon. How we do? So we have closed. We do posterior incision from 10 to 2, as for the watch. We don't open anterior. Zhang is doing a circular opening and enter inside the abdomen. We begin the dissection. It's not in the Ole plane. It is in the plane that we used in the past. And we see the tube will be pushed. It is the same technique of dissection used by the endoscopists for doing mucosectomy. They use a cup at the extremity of the fibroscope and they push the fibroscope to retract. And the retraction is done by the device. Circular retraction that allows to the surgeon to work with 2 hands. The scope is fixed. You see the smoke is evacuated immediately because we don't use high pressure. This is a lateral dissection. This is a mid-rectal artery on the left side of the patient. We will continue to push, as you will see, and we will follow the side wall fascia, the white structures. And along this landmark, we will finally dissect, you see the fascia, we will dissect the propria fascia, medial, and the side wall fascia. And we will find the different branches of nerve crossing. You remember when I have shown from up to down, the different step, we do the same by transanal. These are branches of nerve. We have to dissect. We have not to dissect lateral to the side wall fascia. This is the possibility. We use versatile tools that are able to use monopolar, to cut, to grasp, to divide, to seal. This is fantastic. This is on the other side, and we see the sacral branch, we see the neurovegetative branch crossing the space, we see there. And we will do that till we are finished to dissect posteriorly and laterally. Then we open anterior, and this is a Douglas pouch. We will continue the dissection. You see the tube maintaining the retraction. It's not necessary to have a retractor, and we are working in the center of the tube to finally open the peritoneum at the root of the mesosigmoid, lateral, medial, and we will continue the dissection of the plexus. This is the left branch of the inferior hypogastric plexus. We are at the level of the promontory. We will do that. We do the parietalization. We will see the iliac vessels. We will see the ureter. We continue the dissection. Behind the mesorectum, we enter in the retroperitoneal space, dividing the attachment, finding the anterior aspect of the aorta, respecting the plexus. This is dissection of the lateral attachment of the sigmoid. Normally, we will determine the point where we will do the anastomosis. It is the stitch we have fixed on the summit of the sigmoid. It's only to know where we have to do minimum of resection. We continue the dissection. We see the abdominal cavity inside. As I said, there is no abdominal trocar. We are continuing the dissection. I want to show another case. We see better the IME, the superior rectal artery, and only to show the advantage of the TO. There was the ovarium coming in the field. We push the tube. We have a circular retraction. We can continue to dissect. And we will continue the dissection till we reach origin of the IME. This is the left colic artery. This is a superior sigmoid branch, the aorta, the sigmoid trunk. It was a T1 SM2. Endoscopy said it's enough. Patient was sent to me, we said, it's not enough, it's a young patient. We decided to do a TME, transanal TME, and we have removed 21 nodes, no residual tumor in the rectum, this is IMV, but 2 positive nodes on 21 nodes. That means SM2, it's a 10, 15%, 20% of risk of local recurrence. These are the patients with positive nodes. Until now, we have no possibility to know. Then, when we are finished to dissect, next step is to pull the rectum transanally, divide, pull the sigmoid, control the specimen to see if we have respected the oncologic principles, removing the meso, and this is distal. You see the quality of the dissection. And we will finish doing anastomosis. For that, we pull the colon. We have different possibilities. This is side-to-hand handmade anastomosis. This is endoscopic control. This is end-to-hand susanal anastomosis with the classical stapler, and it was with hemorrhage stapler, the side-to-hand anastomosis. You see the different tricks. When we introduce anvil, you have to be sure to find it, so it's in atraumatically. It's why sometimes we connect to a tube, plastic tube. We control, we do the control. The best results are probably with this side-to-hand with hemorrhage stapler. That is a big anastomosis. You will see the quality of the control. This is a fabulous control of anastomosis. This is a patient I operate in India with his surgeon. It's day 3. You see, there is no diverting stoma. These are patients without radiochemotherapy. I have a recent picture of this patient, very happy. So it is interesting to understand that we can probably do this procedure without diverting stoma. That is the reason why I said that it's not necessary to put trocar. So today, the problem is to know if surgery will be the future to cure the rectal cancer. Or can we use only radiochemotherapy? The woman, the Brazilian woman, she is 85. You see, it's fantastic to be Brazilian and to have some lifting, because it seems she's very young. She described a technique, it's Angelita Arb-Gamma, that is a surgeon, but introducing the preoperative radiochemotherapy or radiochemotherapy, and with her. Arb-Gamma described this concept and found around 30% of complete downstaging. But as I said, complete downstaging, if it is the problem of positive nodes, and I have reviewed a paper, 2 papers, recent paper, there is around 20% of positive nodes in complete downstaging. So we are in the same problem and local recurrence rate. When you have a local recurrence, this is APR, always. Arb-Gamma had a complete response, and finally she pushed a lot of team to consider, is it necessary to operate all the patients or to wait and see? Not enough paper, but more and more are coming to explain and or to help us to decide. What we can summarize. A large number of patients have good downstaging after preoperative radiochemotherapy. For nodal too, but it's difficult to be sure that there is no positive nodes, even if there is downstaging. So pre-treatment stage is irrelevant. And we potentially overtreat a large percentage of patients. So more morbidity for those patients, and it is not what we want for the future. We want to have the possibility to have a better staging, tools that will lead us to tailor the treatment, to customize the treatment. And we know that surgical technique is critical. And this is important to develop oncologic, I will say, local surgical procedure, preserving organs. As for breast cancer, it is the same history of the breast cancer. We were removing the breast, the muscles. Now we try to keep it. And this is the first case I did. It was in June 2011 of transanal TME, removing 15 nodes for multi-endoscopic resection of benign polyp that was T2 when operated, and there was one positive node. So many questions: how to know the staging and the invasion of the nodes, and to evaluate the downstaging. The problem is how to identify the responder. Radiologic predictor, there is no radiologic predictor that can confirm that there is no positive nodes. Using molecular marker, till today, there is no one that can help us to be sure. Having a better per-operative staging, it is what we are developing in our institute. We are using per-operative analysis of the limit of the tumor, using confocal histology, and we determine the exact limit to preserve more sphincter, because is it necessary to resect what I see now, 10 centimeters, when the margin 2 centimeters, it's enough. So people are doing a total mesorectal excision and removing 10 centimeters distal to the tumor, justifying, and perhaps it's not necessary. Using sentinel nodes, it's difficult, but this is a way that we have to work. And question, and Michele, Diana know perfectly this, we have to find a solution. The best is till now not known. After, we have to diffuse and to transmit, to explain, to standardize the different surgical oncologic procedures with limited resection, preserving the organ, and to teach. We have for that the possibility to use technology, particularly augmented reality, that will be used also to navigate, to facilitate the technique of dissection, to see the anatomy with augmented reality, because there is some plane very difficult. The main difficulty is the distance between the different layers, 1 millimeter, 2 millimeter. And the technology today is unable to have this precision. Using, and I do, 3D video, you cannot see, but we have 3D video in 5 millimeter scope. We have developed a system of conversion 2D, 3D to see the dissection in 3D. So we see better the plane, as you can imagine. Developing tools. This is a particular scope called Easy Scope. We have developed, it's an operating system that is introduced. This is through a single port, but transanally, you remember, the cup, we introduce into the TO device, we introduce instrument, surgical instrument for dissecting, coagulating, to make sutures. With Michele Diana, we did in a pig model, in swine model, some ligation of the IME, in retroperitoneal approach. And we are also doing the robotization of the instrument and of the device that will facilitate the use by different people. Next step would be lab training. Big model, perhaps, we have to see, but it is probably what we will do. So, oncologic resection is essential in rectal cancer for optimizing survival and best quality of life. Transanal TME, using the progress technique I have shown to you, it's a surgical procedure that respects the oncological principles in selected patients actually. Using new technology as augmented reality and navigation tool system will facilitate the standardization and the reproducibility of the surgical procedure. Thank you for your attention.
Professor Leroy, we are very thankful for your amazing presentation, and we have time only for a few questions from the auditory. And when you are thinking for this question, I have personally one, if you allow me. I was really amazed of your technique of totally transanal resection, and it was without stoma, as your shows us. And for these days, what actually you could recommend, what could be your indication for putting stoma for patients in such technique?
As I said, it was patient without radiochemotherapy. What we do when there is radiochemotherapy with a good downstaging, we will do a protection, but we will do all the dissection doing a progress technique, complete transanal dissection, and through a single port at the end, we will do the diverting stoma, but all the procedure will be done by transanal, so it's a good training to go to no diverting stoma. Antonio Lassi, we will have a lecture with him tomorrow, if I have seen the program. It said too that the rate of fistula is lower when we do transanal than doing up to down surgical procedures. And I've tried to understand. You know that to prevent some fistula, Bill Hill proposed to introduce a diabolo through the anus to avoid high pressure in the rectum and the anastomotic zone. Other authors, Francesco Corcione from Naples, proposed to do intubation of the sphincter to maintain the sphincter open to avoid the high pressure inside the rectum. And we do transanal approach. We use a TO. It's a 4 centimeter diameter tube. We introduce atraumatically to have dilatation, but a long time. And post-operatively, those patients will have, for the major, except the younger one, will have some partial incontinence. The sphincter is relaxed, and there is no spasm of the sphincter. And during 1-2 weeks, one patient had, during 4 weeks, had partial incontinence. And this is due to the dilatation of the sphincter. So we reproduce, perhaps, the prevention of fistula because there is no high pressure in the anastomotic zone. And what would be the indication? I will say all the patients with easy sutures without problem will have no diverting stoma if they have had no radiochemotherapy. But I'm surprised for your question because in Japan, where I was, they don't do diverting stoma. They do in 10% of cases. They don't use radiochemotherapy. It's West countries. They are using more and more. We have a Japanese colleague and he can confirm what I say. They use in 10%, it's mainly for advanced case, for T4. So this is one of the factors that push us to protect. But normally, in Asia, they don't do. Majority of cases, they don't do. This is a problem of good vascularization. If you do a large dissection as we do in our country, it's not necessary for cancer, but we explain that we have to remove all the sigmoid for a rectal cancer. It's not justified. But we say, yes, but we have diverticulosis. We have a bad sigmoid. And it's true that in Asia, they have a long sigmoid loop. They are lucky. So they don't mobilize the splenic flexure, and they do the anastomosis on the sigmoid loop.
Thank you very much. Any other questions from the auditory? Если есть какие-то вопросы, мы можем один-два вопроса перевести. Есть большая возможность, учитывая, что такой уникальный гость у нас сегодня, спросить о любых хирургических вопросах по колоректальному раку. Okay, then. Thank you very much, Professor Leroy.
Okay.
We will continue.
What another?